This video is about ZENKER'S diverticulum. First, let's see what's esophageal diverticuli. Esophageal diverticuli are outpouchings of one or more layers of the esophageal wall, and it could be true diverticuli, which contains all the layers of the esophageal wall, or it could be a false diverticuli, which means it contains only the mucosa and submucosa layers of the esophagus. As we can see in the picture, this is a true diverticuli, which contains the muscular layer, the submucosa, and the mucosa, while here there is no involvement of the muscular layer, so which is a false diverticuli. Then what's ZENKER'S diverticuli or pharyngeal pouch? It's defined as a posterior false diverticulum that has a neck proximal to the cricopharyngeal muscle. As we can see, which we will see in the diagnosis as well, this diverticuli with a neck and outpouching. This is endoscopy, which is the esophagus, and this is a false diverticuli. How does it develop? It emerges from a naturally weak area in the muscular layer of the hypopharynx, which is known as the Killian's triangle, which is formed by the oblique fibers of the thyropharyngeal muscle bilaterally, and the horizontal layer, the cricopharyngeal muscle. So here the triangular area with the weak part, which is called the Killian triangle, where the false diverticuli named ZENKER'S diverticuli occurs. As you can see, this is the lateral part and this is the posterior part. So predisposing conditions include disorders associated with altered upper esophageal sphincter function, abnormal esophageal motility, or esophageal shortening. The prevalence, symptomatic ZENKER'S diverticuli are more common in males, and also with age, it is in middle age and old age adults. Clinical feature: small diverticuli may be asymptomatic. ZENKER'S diverticuli should be suspected in middle age or old age adults with progressive dysphagia, usually through solids and regurgitation of undigested food debris. And when the opening of the large ZENKER'S diverticuli are often aligned with the axis of the pharynx, such that food is preferentially diverted into the diverticulum, and when the pharyngeal sac becomes large enough to retain content such as the mucus, the pills that we take as medicines, or the sputum of food, the patient may complain of halitosis, which is a bad odor, and gurgling in the throat, and appearance of a mass in the neck, or regurgitation of food into the mouth. So marked weight loss and malnutrition can also occur in patients with long-standing dysphagia, and in rare cases that may become so large that its retained contents may push anteriorly and completely obstruct the esophagus. So diagnosis is mainly by barium swallow, as we can see here, and endoscopy can also be done, but not to confirm the diagnosis, rather for malignancy screening. If someone cannot take the barium, one can do a transcutaneous ultrasound to diagnose, as well as to differentiate it from other neck masses. Management: if the patient is asymptomatic and the diverticuli is small, that means less than 1 centimeter, it doesn't need any treatment until the patient becomes symptomatic. If the size is above 1 centimeter or the patient is symptomatic, one can intervene with surgery or endoscopic procedures so that the diverticuli will be managed. Complications include aspiration pneumonia, ulceration and bleeding due to retained medication, fistula between the diverticulum and tracheal lumen formation, vocal cord paralysis due to the pressure from the retained food, and squamous cell carcinoma in the diverticulum is a rare complication with an incidence of cancer from 0.3 to 1.5%. Risk factors for malignancy are old age, male gender, long-standing history of diverticuli, and larger diverticular size. Thanks for watching. If you find any valuable information in this video, please consider subscribing and liking the video. Thank you.